I think so. I'm audible to everyone. This is Dr. Aravind. Am I audible?
Yes, doctor.
Yeah.
Just give me a minute.
Yeah.
So,
Okay.
hello and good evening to everyone here. So this is again another INICET series which we have started today. So the one today we will be discussing on orthodontics, and it will be done by Dr. Aravind Sampath, and he's an MDS in orthodontics. So he will be discussing a few questions, and he'll also be telling you like how to go about with each answers and other discussions. And I think he has got something interesting at the end of the session as well. So please stay till the end and get your doubts cleared, and please be interactive, and let us learn together.
Thank you, Dr. Lakshmi. That was a wonderful introduction. So let's get into this orthodontic question series. Before getting into orthodontics and analyzing different questions and various question papers, and it's been very clear that the weightage given to the orthodontics is quite very high. And there are two types of questions that are being discussed. One which is purely related to orthodontics, and one which is remotely related to orthodontics. The one which is purely related to orthodontics will be easy one to answer for everyone, I hope. And one that is related to orthodontics will be related to other departments such as endo, prosto, and perio. These are the three departments, and pedo. These are the four departments which plays an important role combining with ortho and giving a confusing types of questions for everyone to be answering the right answer. So here, before getting into the presentations, I hope everyone are doing good in this COVID pandemic era, and everyone have good food and a healthy lifestyle before entering into and giving these competitive exams, and never fail to enjoy the life while reading or during the exam preparation times. And Dr. Lakshmi has also asked me to keep this session as interactive as possible, and I hope I am interactive. And please be interactive as possible. And if you have any doubts in between, you can interrupt me in between, or if you are comfortable with the questions at the end, you can have the questions accumulated and you can ask them at the end. I'll be pleased to answer them. And if I don't know, I will get to you as soon as possible. So on seeing the first question, the tongue develops during the fourth intrauterine week from the second branchial arch, and the following statements are there. That is, the statement is correct. Only the period of initial development is correct. Only the site of development is correct.
Doc, yes. Just again, are you sharing your screen, something like that?
Yes. Is my screen visible?
No, it's not. Not yet. There is no share screen.
Okay, fine. Now is it visible?
Yes, doc.
Yes. So this is the first question. At first, it might seem that it is purely related to anatomy, but it is also related to orthodontics. Let me say how it is related to orthodontics. The tongue develops during the fourth intrauterine week from the second branchial arch, and the following options are given. Statement is correct. Only the period of initial development is correct. Only the site of development is correct. Both period of development and site is correct. So the notion in which these questions are asked is to distract the individual from answering the right answer. And there are two parts in it. One is the fourth intrauterine race, and the other one is the second branchial arch. So either both the things can be correct, or either one of the things can be correct, or both the things can be wrong. So in order to easily understand and to retain such questions in mind, you will have to relate such types of questions to either of the departments that you know. So to my knowledge, the most closely related department to this question will be orthodontics, because this is the area where the malocclusions are being related to the tongue area. So there is a person called Balter who introduced certain appliances to correct the functional class 2 malocclusion. He believed that the tongue plays an important role in contributing towards the development of malocclusion. That's what he believed, and he also proposed certain appliances to correct these functional appliances. So from this point of view, it is well versed to know that the development of the tongue is most important in order to understand these types of appliances. So what he says is the tongue plays an important role in the development of class 2 malocclusion. Let's get into the discussion. The discussion states that anterior 2/3 from the two lingual swellings and tuberculum impar from the first arch supplied by the mandibular nerve. Posterior 1/3 from the anterior half of the hypobranchial eminence from the third arch supplied by the ninth nerve. Sulcus terminalis forms the line of fusion between the two parts. What develops from the second arch is the hyoid bone. Now, I'm answering the question that the tongue develops during the fourth introuterine week from the second branchial arch. Only the period of the initial development is correct. That means from the second branchial arch, the developing structure will be the skeletal derivatives would be the stapes, styloid process, stylohyoid ligament, and part of the hyoid cartilage. And the important cranial nerve which is associated with this branch will be facial nerve. That is the seventh nerve. So the arches that are to be remembered when studying the tongue will be the first and the third arch alone. And at what week it is being developed? It is being developed at the fourth introuterine week. So when coming to the Baltus, he believed that the tongue played an important role in developing a malocclusion, which is more towards class 2. And he also proposed various other modifications of the appliances, which involves for the correction of class 2 division 1, division 2, as well as for a class 3. So he formed an appliance, which I think so we'll be discussing about the appliances which has been proposed by Baltus at the end. We'll be having a poll so that we will have an interactive session on how easy it is for you to pick up the answers from the discussion that we are going to do now. So there is a part in Baltus appliance wherein which there is a palatal U-shaped bar which helps the tongue to maintain in its physiological position. So he thought and he proposed an idea wherein which the tongue playing a major role. If it is placed in a misplaced position, then it might lead to constriction of maxilla and retruded position of the mandible. In orthodontics, whenever we are going to deal with a patient, we will be dealing with the patients under various terms. One, dealing with the dentition alone, and the other, the skeletal basis holding these dentitions. So the patients may be coming with the problem only with dentition, problem only with the skeletal basis holding these dentitions, or there may be a combination of both these things. What he said is these functional corrections can be made through an appliance which he proposed, believing that which corrects the normal positions of the tongue. So this is how the knowledge of the tongue plays an important role towards the development of the malocclusion, and which will be easy for you to understand all these things and to retain all this knowledge while giving the questions and the answers. So what are the following questions that have been addressed? What are the developmental stages of the tongue? At what time these tongue develops? What are the branchial arches which are contributing towards the development of the tongue? How tongue plays an important role towards the development of malocclusion? Who proposed this theory? And what is the appliance that is being proposed by Baltus? These are the various questions that can be associated with the development of the tongue. I hope I'm clear, and I'm going to the next question. The outer layer of Venn diagram in Ackermann and Profit classification. The options are alignment, profile, transverse relation, and vertical relation. So these are the two great authors who proposed a classification to overcome the various drawbacks that has been proposed by Angles. Angle was one of the forerunner who proposed a classification which even stands today and is being widely used, and it is very simple to communicate, and it is very easy to understand, and it is very easy to communicate with the fellow dentists and the patients. And on accounting for the various drawbacks that Angle classification has seen, Ackermann and Profit has given a more complex type of classification which includes all the types of deviations in the transverse, sagittal, vertical, different types of malocclusions involving the face and the crowding and spacing and the interarch relationships. Everything has been covered in this. But this also suffered from various drawbacks, as it is very cumbersome to understand and it is very cumbersome to communicate with the fellow dentist and to understand. So there are two types of question here. The question is the outer layer of the Venn diagram in Ackermann-Profit classification. So one must understand the choice of words that they have played in here. That is the outer layer of the Venn diagram. People usually go to the outermost layer and select the answer as intra-arch alignment symmetry, and they would be going for an alignment option, which would be completely wrong. And the question that they have asked is outer layer of the Venn diagram alone. That is, the Venn diagram is the intersections of all the spheres which is present here. Okay, so this becomes the outer layer of the Venn diagram. So all these three circles, which comprises of transverse, sagittal, and vertical, which is being comprised inside a larger circle. So the things and the constituents which are present inside this larger circle will form the outer layer, and the question is not the outermost layer. So the outermost layer forms the group 1 intra-arch alignment symmetry, which also includes the crowding and the spacing and the ideal alignment of the dental constituents. So the most ideal answer for this would be profile, and people would be tempted to choose the option A, which is alignment. And the following questions can also be arised from these types of Venn diagram question. That is, Ackerman at later point of time also introduced three terminologies, that is pitch, roll, and yaw. You can see pitch, roll, and yaw. These are not the sole terms which are coined by Ackerman towards orthodontics. He borrowed the term from aeroscience and introduced it in here for easy understanding and for easy communication. That is, say a patient like this coming to a clinic with a severe type of malocclusion, one cannot just rely upon angle systems of classification to explain about or to communicate or to record the type of malocclusion that the patient is having. So here, the malocclusions of the patient should be assessed for the face, for the dentition, and as well as for the axial inclinations of all the structures, including the teeth as well as the jaw bases. What is meant by pitch? Pitch means the pitching up and down of the facial structure. That is considering an aeroplane which is in a three-dimensional space with no reference to be searched around. That means it must be described in certain terms that it is pitching down, pitching up, it is moving on the right or the left, or it is rolling on the right or the left. So by these terms, he has termed pitch, roll, and yaw. Pitch means pitching up and down. So the movement of any object around an axis which is passing through ear to ear. When an axis moves from right to left and the object tends to move up and down, this means pitching. What is meant by roll? Roll is to move sideways like this. That is movement of any object across an axis running forwards, backwards. So if an object is pivoted from back and front, it will have a tendency to rotate on its own axis towards right and left. This means roll. And what is meant by yaw is the rotation of any object around the axis running from up and down. That is, it will be moving this way. So by introducing all these terms, Ackerman was able to analyze and communicate the type of malocclusion which is present in these types of patient by saying at what axis the real malocclusion lies. So now here the question that can be asked will be, what are the recent trends towards describing a malocclusion that is being proposed by Ackerman? And you can choose the answer pitch, roll, and yaw. So here the types of question which can be confusing will be the outermost layer of the Venn diagram and the outer layer of the Venn diagram, and what are the different types of modification that has been proposed by Aker at later time, that is pitch, roll, and yaw. So while giving these types of questions, one must try to understand the choices of the words that the examination is going to take place, which plays a very important role. And this is the reason why immediately after finishing our 12th standard examination on giving an AIMS paper or giving a NEET paper, a special notion about understanding of the English language is always being given to. This is because to confuse the person and to exactly collect the individuals from a greater population towards the desired number of seats. Next, moving to the next question will be, how many vertebrae are present in the human body? This is also another anatomical question which plays an important role towards orthodontics. Only when you associate such type of questions to any other department, you will be able to understand and easily recall things into your memory when you are giving an examination. The options will be 33, 34, 35, 36, and 45. These are the types of options that you will be given. So the average person is born with 33 individual bones that interact and connect with each other through flexible joint called facets. By the time a person becomes an adult, most have only 24 vertebrae, and most will be confusing with 26 number of vertebrae, but the options will be only 24 vertebrae because some vertebrae at the bottom end of the spine fuse together during normal growth and development. So what are the other two vertebrae that are missing when while the mention is only 24 vertebrae? Try to have an interactive session. If you are able to find an answer for the missing two vertebrae that I have not mentioned, you can mention it at the last. So the vertebrae that are playing an important role towards orthodontics will be these 7 vertebrae in the cervical region. Why are these important? This is very important towards determining the amount of growth left for an individual that can be utilized by the clinician for compensating of the differential growth between the maxillary and the mandibular skeletal bases. So by this, patient will be coming with a class 2 dental base, or a patient can be coming with a class 2 skeletal base as well as a class 2 dental base. So if a patient or a child is coming to clinic and you are observing that the patient is having a class 2 skeletal base with a retrognathic mandible, that is mandible positioned far back in comparison to that of the maxilla. So the clinician will try to grow the mandible according to the age of the patient. So at certain particular age of the patient, the mandible tends to lengthen to a greater extent and maxilla tends to lengthen to a greater extent. So by this statement, you will be understanding that maxilla as well as the mandible tend to follow different growth curves. By the term growth curves, you will have to understand something called as a Scamon's growth curve. Scamon's growth curve always explains about the type of growth curve that the maxilla or the mandible follows. The maxilla always follows the growth curve of that of the cranium, that is the brain. That means the growth of the maxilla completes first, then followed by the mandible. Mandible will always follow the somatic growth curve, and it will be 12 to 14 age distribution. And it is only during this period the mandible shows its highest increase in length. So a clinician will always try to give a functional appliances tending to increase the length of the mandible only during this period, wherein which the mandible shows its highest growth curve. If the clinician chooses to give functional appliances before starting this peak pubertal velocity of the mandibular length, then he might have to wait for a longer time until the mandible reaches its peak height velocity. That means extra cost for the patient, extra time duration wherein which the patient is being subjected to the appliance wear, which is very cumbersome and which will ultimately lead to patient burnout. Burnout refers to patient dropping out of the clinic and he is completely aversive of that of the dental treatment that the clinician is going to give. The next possible question will be, what will be the maturation stage for a particular individual demanding for a maxillary orthopedic forces or the appliances? It will be maxillary CVMI stage 2 and stage 3. That means if you are going to alter the maxilla, you will have to produce an orthopedic force when the patient is well within the CVMI stage 2 and stage 3. If at all, if the patient requires the growth of the mandible, then functional appliances should be given only during the CVMI stages 3 and 4. 2, 1, 3 for maxilla and 3 and 4 for mandible. The next anatomical question that will be related to orthodontics will be, what are the 3 most important cervical vertebrae that can be utilized for CVMI staging? So as you can see in the picture, these are the 3 cervical vertebrae. This is C3, which means this is C3. This is C2. Most persons will be opting to choose that this vertebrae will be C1, but it is not, it is C2. You can also answer in the last by naming what are the cervical vertebrae 1 and cervical vertebrae 2. This will be another question which will be used. The options will be axis. One will be for axis and the other one you are going to guess it at the last. Okay. So the cervical vertebrae that are going to be assessed in the CVMI stages are not C1, 2, 3, but they are C2, 3, and 4. The cervical CVMI stages are to be assessed only in the cervical vertebrae 2, 3, and 4, and not 1. What are the various stages that can be seen or observed while the patient is growing, which can be stated as initiation, acceleration, transition, deceleration, maturation, and completion. In order to easily remember this, PGs used to remember it as an I at DMC, which will be an easy way to remember things. So what are the key differences that you are going to observe through these stage 1, 2, and 6 will be the lowermost border of the C3. So as you can see, from stage 1 to 6, the lower border turns from a flat surfaces to a mild curved surfaces to the most curved and a most rectangular cervical vertebrae. So this means when the individual goes from initiation to completion, the growth has been completed. When is the maximum mandibular length happening is between the stage 3 and stage 4. If at all you are lucky with a patient with stage 4, that is a deceleration stage, then the patient will be around the peak pubertal growth velocity. You can utilize that peak pubertal growth by giving a functional appliance to grow the mandible to a greater extent. And if you are going to control the growth of the maxilla, it is always seen that the maxillary growth cease by CVMI stage 3, and it is well if you give between CVMI stage 2 and 3, that is during the stages acceleration and transition. So from the cervical vertebrae questions, the number of questions that can be asked during the examinations will be numerous. Anatomically, the type of bones, the number of bones, and what are the bones that can be used for the cervical maturation index, how much of the maturation that is being left that can be utilized by a clinician for the growth of the maxilla or the mandible, or is there any other method to identify the growth stature of an individual apart from CVMI. So these are the number of questions that can be asked associated with anatomy as well as to orthodontics. If you are going to relate such types of question to orthodontics, it will be very easy for you to remember and to reproduce during the examinations, and it will not take so much effort to remember these numbers when you're going to associate such types of questions to various departments. So the answer for this will be 33. There are 33 number of vertebrae which are present in the human body, which is going to reduce to about 24 vertebrae apart from the 2 vertebrae that are going to be discussed at the last. So which of the following inhibits bone resorption? This is a physiology related question, which is also playing a very important role towards the understanding of how the tooth moves inside the bone. So there are various chemical molecules and biochemical molecules which playing an important role towards the tooth movement inside an alveolar bone, among which PTH, interleukin 1, interleukin 6, and osteoprotein playing an important role towards development of a concept called as rank-rankle pathway. Now, before jumping into the answer on how to choose it, never go to an option which is a long one and I'm going to choose it. It is going to land you in trouble in most of the times, and it will also show the type of molecular changes that has been happening inside the body when a force is being applied to the dental structure. So this is a rank-rankle pathway which explains about the molecules that has been playing an important role towards resorption as well as bone apposition. So rank is a receptor here, and there is a protein called as a rank-L, which is a ligand, and there is another protein called as an osteoprotein, which is an OPG. Just try to understand and remember that the rank and the OPG are similar in shape, and it tries to capture and compete with this ligand rank L. So what this is the exact catch for the rank and the rankle, and the OPG tries to be acting as a decoy protein for the rankle. So if at all OPG catches the rankle first, rank will be free and the pre-osteoclast will not be activated further to form a full-fledged multinucleated osteoclast. That means there is no resorption, and that means there is no tooth movement. So if OPG tries to compete with rank and cancels the rankle first, there is no osteoclast formation, thereby leading to no bone resorption. That means absent bone movement. So what are the molecules that are going to promote the combination of rank-rankle will be interleukin 1 alpha, 1 beta, interleukin 6, tumor necrosis factor A alpha stimulates the bone resorption, while OPG, a decoy protein which is mimicking rank and tries to capture rankle. So this is a very small depiction of what is happening in a very large scale, and it is very also easy to understand. There will be no further questions on to further molecules that has been activating the rankle, which is going to be highly tiring, and it is going to be highly difficult to remember all those molecules. And the questions related to the entrance exams will be completely related only through these molecules, that is interleukin 1 alpha, 1 beta, 6 tumor necrosis factor alpha, and osteoprotegrin. And the pathway that I have described here is called as a rankle pathway, named after the ligand and the protein which is present outside the pre-osteoclast. In other words, the questions can be, where does these osteoclast arises? Osteoblast control the formation of the osteoclast itself. That means in the absence of the osteoclast cannot be formed. So the master cell which controls all these molecular changes facilitating the tooth movement will be osteoblast alone, from which osteoclast arises, which in turn controls the osteoblast again, which forms a cycle. So this is how a question from a physiology will be related to orthodontics. So now coming to the question, which of the following inhibits bone resorption? Parathormone, interleukin 1 alpha, interleukin 6, osteoprotegrin. The answer will be osteoprotegrin, as osteoprotegrin is a decoy protein for the rank protein, which has been present in the outer layer of the osteoclast. This is a core ortho-related question which needs to be by-hearted, and there is nothing more to understand in this. For each millimeter of retraction of a protruded teeth, spacing required will be 0.5 mm, 1 millimeter, 1.5 mm, and 2 millimeter. The answer will be 2 millimeter. If all the 4 lower incisors are advanced by 1 millimeter, additional space will be created distal to the incisors by an equivalent amount on each side, totaling 2 millimeters of space. Conversely, retraction of either the upper or the lower incisor is a space requirement. A 1 millimeter of retraction of all the 4 incisors will require 2 millimeter of spaces. So the answer will be 2 millimeter. What are the other types of questions that can be related to such numerical questions will be, for 1 degree of retraction, what is the equivalent linear measurement that is being produced? Understand, whenever an incisor is being retracted from a proclined position, it is to be assessed by 2 means. One is by angulation and the other was by linear measurement. So if an incisor is going to be retracted to about 1 degree, what is an equivalent linear measurement that is being required for that retraction of 1 degree? That the answer will be 0.8 mm. That means for 1 degree of retraction, you will be requiring 0.8 millimeter of space. These are the 2 types of question that can be related to numbers. Here the question is, for each millimeter of retraction of protruded teeth, spacing required will be 2 millimeter, equally distributed for all the 4 incisors. So here the question has no specificity about the amount, the number of incisors that is going to be retracted. If at all, the question is more specific about the number of teeth requiring the retraction, then you will have to divide the 2 millimeter to the number of teeth that is being asked. Here, there is no mention about the number of incisors. If at all, the question has been about the retraction of all the 4 incisors, the answers that would be best choosing will be 2 millimeter. This is a picture type of question. Do not go by the misleading nomenclatures that has been very fancy in orthodontics. Identify the type of appliance that is shown here. The answers are distal jet, mini jet, fast back, and carrier. All the 4 appliances are really in use in present day in orthodontics. So in order to understand the type of diagram that has been shown in the screen, you will have to know what all the 4 appliances are: the distal jet, mini jet, fastback, and the carrier appliances. So the correct answer for this will be fastback appliance. This is called as a fastback appliance. This fastback appliances tends to distalize the molar by taking anchorage from the premolars as well as from the canine. There is also an acrylic plate here which tends to take the anchorage from the soft tissue and the hard palate. So this is a combination type of an anchorage appliances which takes anchorage from the soft tissue, hard palate, the palatal shelves, premolar, as well as from the canine. So what is the importance of speaking anchorage over here in this appliances is it is trying to move the molars distally by taking anchorage from the premolars as well as from the canines. That means the premolars and the canines are also trying to move forward as and when you activate this appliances. So these are nothing but a type of jack screw which is still reduced in size to an extent that it is placed towards the right and left palatal shelves, and there is a jet here with a niti coil spring which when you activate is going to compress these niti coil springs and then it is going to distalize these molars. The amount of space that is being gained will not be completely by the distalization of the molars, but also will be from mesialization of the anterior segment. That means we are going towards the term called as an anchorage loss. That is, the premolars are not going to resist the movement of these molars, as these molars are larger in surface area with 3 roots, 1 long palatal root. So the molars are also tending to rotate during the rotation, as well as the premolars and the canines will tend to move forward, coining the term called as an anchorage loss. Now, what's the difference between this appliance and this appliance? This appliance will not be using jack screws as mentioned here. This will be using only the niti coil springs. These niti coil springs on activation will produce a distal force movement which produces distalization of the molars. This is an appliance which also produces distalization, and the name of this appliance is called carrier appliances. This is a very interesting appliance which also tends to correct the cant of the occlusal plane in the forward-backward direction. Imagine elastics extending from the lever which has been attached to the molar to that of the lower molar. It is going to rotate the maxillary segment in a clockwise direction. So the maxilla tends to rotate like this when the molars are going to get mesialized, and these molars, the upper molars, are also trying to get distalized by the pull of this elastics. This will be a normal class 2 elastics which can be extended from the hook of this lever to that of the molar. So a combination type of force can be visualized here. One will be distalization of the upper molars, mesialization of the lower molars, extrusion of the lower molars, and the total maxillary occlusal plane will tend to rotate in a clockwise direction, tending to bring down the maxillary incisors down and the maxillary molars up. So this is a very complex appliance and it's a very cumbersome appliance which requires a large amount of patient compliance to wear the elastics that has been provided by the clinician. So from the appliances, we will be having 3 different types of appliances. One will be carrier appliance, one will be distal jet, and the other will be fastback appliances. What will be mini jet? Mini jet is nothing but a refined form of a distal jet, and this has been developed to counteract the amount of anchor loss that I was speaking about a few moments back, to reduce the amount of the anchor loss. That is, the whole appliances will be anchored to that of a mini implant which is placed in the palatal shelves in the anterior region. That means the premolars and the canines will be having less tendency to move forward, and thereby increasing the efficiency of the molar distalization just by distalizing the molars. So mini jet will be a form of a distal jet, but with a combination of the mini implants. So any appliances that we are going to deal with will also have a component called as mini implant supported appliances. The names will be misleading and it will be very confusing, and these are all very fancy names, and these names are termed in such a way to promote the appliances for many clinicians to be using it. This is called as a carrier appliance, this is a fastback appliance, and this is a distal jet. And if it comes with a mini implant, then it forms a mini jet appliance. Identify the following appliance: echo, pendulum appliance, pendex appliance, and a finger spring. So here the type of confusion that you will be having on seeing this appliances will be a finger spring appliance bilaterally placed mesial to that of the maxillary molars. So you will be tending to choose a finger spring for the molar appliance, but it is not. This is a very old appliances which has been introduced into orthodontics by Leonard Margolis in 1969. which is called as an acrylic cervical occipital appliances, which is being followed and modified by a doctor called Giuliano Maino, who introduced the second generation of the Acco appliances, and he introduced after a very long gap of 2008. Almost 50 to 60 years of differences between the generation 1 and generation 2 appliance. What does this appliance do is to distalize bilateral maxillary molars just by the use of a finger spring. The components will be an anterior bite plane, a south end clasp which promotes anchorage, which is placed in the central incisors of maxilla, an Adams clasp bilaterally in the premolars, and a finger spring in the bilateral molars, which is placed mesially to distalize the molar. So what is the major difference between first generation and second generation is that in the first generation, the distalization of the molars will be carried out through an appliance called as an headgear, which facilitates the distal movement of the bilateral maxillary molars. So the name involves acrylic cervical occipital appliances. So the molars are planned to move cervically and occipitally with the help of an headgear, which later in the second generation was replaced with that of a finger spring that is placed bilaterally mesial to that of the molars. So there are two types of question. One will be the identification of the appliances, components of the appliances, that is by the name mentioned Acco, and who was the first person to introduce the first generation, how long was the difference between the development of the second generation, and at what time the second generation was developed and by who was it. What is this type of an appliance? This type of an appliances is most widely used in pediatrics, but it is also widely used in orthodontics in a different form. The most widely formed appliances that is being followed in orthodontics, which is similar to this, will be riding pontic appliances. So this is called as a Groper appliances, which is being proposed in 1984. The sole purpose of this Groper's appliances is to rehabilitate the lost incisors that are for the children. So whenever a children comes with a trauma or with an excessive caries, who have lost all the anterior teeth, the Groper appliances can be given, rehabilitating the anterior segment, establishing the proper smile for that individual. That is, molar bands will be present bilaterally in the maxilla, which is being attached with a palatal bar extending in the anterior region, which connects all the 4 anterior teeth. The anterior teeth can be missed by 1 unit or 2 unit, or as a total of a 4 unit, which can be all put together by forming a group of appliances. So this is a rehabilitation type of an appliance. Who introduced the above premolar classification? The options will be Baum, Ackerman and Profit, Katz and Ballard classification. So here, Katz is the answer, who introduced this premolar classification. Katz always follows with the suffix of premolar. So it always goes as Katz premolar classification. So if at all a question is being asked with a premolar in the question, then it always been prefixed by Katz. Katz was the person who introduced this premolar classification. He described these types of classification also on the drawbacks of what angles classification suffered from. So it can be of 4 types. One is class 1, half unit class 2, full unit class 2, and a class 3. So class 1 and class 3 will be easy to remember. That is, the lower premolar will be well ahead of the median of the upper premolar, and the class 3 will be well ahead of that of the class 1. That is, there will be a gap between the maxillary first premolars and the mandibular first premolars. In the class 2 half unit and the class 2 full unit, there will be a difference between the cusp to cusp relationship and the mesial slope and the distal slope of the lower premolar and the upper premolar respectively. So the questions will be, who introduced the premolar classification, and what are the other classifications which are being introduced by Baum, Ackerman and Profit and Ballard. So the first picture depicts Katz premolar classification, and this is the incisor relationship, which is very widely called as British incisor classification, which is developed from the classification proposed by Baum. So Baum was the first one to develop, which was later developed to form British incisor classification. So, when a question is being asked about incisor classification, there are 2 names that are to be remembered. One will be BOM and the other will be British incisor classification. Both are closely related to each other. British was the latest one, and BOM was the pioneer one to introduce the classification. And what is this classification? This classification is widely being used by the periodontist to show the relationship of the primary molars, be it a mesial step, distal step, or the straight flesh edge relationship. So this has been produced by Ballard. And what is this classification? If a picture is being given and to identify the type of malocclusion that is to be addressed for a patient will be Simon's classification. So if this is the kind of an picture that has been given to you to answer the question, kindly go for Simon's classification. This can also be confused with the question pitch, roll, and yaw, which is very similar to this classification. One of the major difference that we're going to find in this type of a picture is the second plane, which goes towards the Frankfurts, and the third plane, which always bisects the canine. So the third plane always bisects the orbital plane as well as the canine, by which Simon gave a law called as Simon's law, canine law, which states that the orbital plane passing through the orbit should pass through the bilateral canines. And he also introduced classification on all the three planes, that is transverse, vertical, and sagittal. In the transverse, he called as a contraction or distraction, that is maxilla being contracted or distracted. In the vertical, he called it as an attraction or an abstraction, where means the mandible being closed to the maxilla or opened in relation to the maxilla. That is, a horizontally growing patient will be calling as an attraction, and a vertical growing patient will be called as an abstraction. In sagittal plane, the classification would be explaining about protraction and retraction. Imagine this being the maxillary and the mandibular incisor. He called it as an protraction as well as an retraction position. So the Simon's law and Simon's classification always focused on the facial structures, and it did not consider the dental unit that has been considered under various malocclusion strategies. This is another picture question where a player has been will be shown, and identification will be asked for. The options will be distal end cutter, Matthews forceps, Weingart player, and Tweeds player. The main confusion that will be arising on seeing such types of picture is to identify under what departments or under what specialty these pliers will be used for. Pliers will be used in surgery as well as in orthodontics. So we will have to make sure where these instruments are being used. The picture that has been shown here is distal end cutter, and these are the other pliers that are being described in the options. This is Matthews forceps. Matthews forceps is a forceps which is used to hold the needle. There will be a serration here in the beak region, which helps to hold the needle, as well as it is also used in orthodontics to place modules. That is elastic which is used to hold the wire or to fasten the wire to that of the brackets. So these are the two areas where the Matthews forceps will be used. Matthews forceps will also be curved, and it is a needle holding appliance in all instrument also, but it is also used in orthodontics to place various types of elastics. Weingart player. Weingart player is a player that is used in orthodontics to bend the wire distal to that of the molar, so that a cinched back can be done. A cinched back is nothing but bending the wire distal to the molar to prevent proclination of the incisor. So this is a Weingart player and Tweeds player. Main difference between the Tweeds player is it consists of two types. One is the arch forming player, and other one is loop forming player. This is Tweeds loop forming player, and this is Tweeds arch forming player. This will be very similar to another instrument that as an EUG you will be using it always. Do not confuse with that appliance, which is an universal appliance. This is nothing but a Tweeds loop forming player. Both this appliance and this appliance will be Tweeds player. This is another question that was given to me with an incomplete options. That is not a method to accelerate orthodontics. One is corticotomy, injection of a parathyroid hormone, use of fibrin, platelet-rich fibrin, and perisession. this will be an odd man out where precision is the odd man out, where the other three options are being very widely used towards accelerating the orthodontic treatment. The success of the accelerated orthodontic treatment is another topic which will be discussed widely in the specialties. Let's not get into those topics. What are the various methods that can be used to accelerate the orthodontics? It can be classified into biological, surgical, and device assisted. The biological agents that are used to accelerate orthodontics involves cytokines, prostaglandins, vitamin D3, parathormone. Remember, vitamin D3, parathormone always goes hand in hand towards accelerating orthodontic tooth movement. Surgical treatment involves osteotomy, corticotomy, microosteoperforation, and piezo-excision. And device assisted involves LIPUS. LIPUS, remember this term LIPUS as an ultrasound. So LIPUS is nothing but an ultrasound facilitated accelerated orthodontic device. Photobiomodulation, which involves low level laser therapy, and BioLux Orthopulse. BioLux Orthopulse is a brand which introduces various devices with various LED projection light on an hypothesis that it will increase the orthodontic tooth movement rate. And there is also a cyclic force device, which is nothing but an axle dent. This axle dent provides vibration in the oral cavity, which is hypothesis that it also might promote the acceleration of the orthodontics. The questions regarding to photobiomodulation will be low level laser therapy and the nanometers of the wavelengths that has been used. Infrared wavelength of about 600 to 1000 nanometer are widely used in the low level laser therapy. And LIPUS uses ultrasound for accelerating the orthodontics. Now let's get into the poll. I think so the poll has been visible to everyone. Am I clear? Hello. Hello.
No, Doc, we're not able to see any board.
Now?
No.
I think so. It must be visible now. Is it visible?
We were able to see the polls.
Yeah. I request everyone to answer the polls, and let's see how many of them get them right. If everyone gets them right, then I will be happy that I will also have made a decent job in making everyone understand what today's session is about. So it's a two-way discussion. I have shared my knowledge about orthodontics to you, and now enlighten me by saying how far I am right and how far I am succeeding in this session. I think so I can end the poll. Has everyone answered it? Can I say an yes from the group chat from everyone? Yes, it's been 1 minute and 20 seconds, and I'm going to end the poll. Let's discuss the poll answers now. Share results. Yes. And coming to the first question, who proposed that the tongue dysfunction as the sole purpose of malocclusion? There has been mixed answers. The answers are Baltus, Charles Tweed, William J. Clark, and Andrews. Fine. So there is no one answering Andrews, which is a very good thing. And who proposed the tongue dysfunction? Charles Tweed and William J. Clark. 25% of the population has answered this question. So the right answer will be Balter. Balter has proposed an appliance called Bionator, which corrects the malocclusion by correcting the correct position of the tongue. So always Balters go with a prefix called as Bionator. Remember, Balters Bionator, tongue dysfunction. So always when a tongue dysfunction question comes into the question paper, you must always remember the term Balter and Bionator. Charles Tweed and William J. Clark. William J. Clark has identified, proposed an appliance called as a twin block, which has been widely used towards class 2 correction. Charles Tweed has a various contribution towards orthodontics by forming Tweed's plier, Tweed's archware forming plier. There is a separate Tweed's appliances which were followed previously, which is not followed abundantly now. So here the question will be an odd one out, because Charles Tweed is completely different from that of the tongue. William J. Clark can be confused with Balter, as this is also, and he has also produced a functional appliances. And Andrews has produced straight wire appliances, which is completely different from all the other options. So the correct option will be Balter's. Next, going to the next question. From the following, what was Balter's contribution to orthodontics? Many have answered activator. Activator is not the right answer. Balter's is the right answer, as Balter has proposed an appliance called as a bionator. Okay, so many have answered an appliance called activator. Activator is one of the forerunner of all the functional appliances, which has been proposed to correct the class 2 malocclusion towards the correction towards the class 1 malocclusion. And there are various modifications of it, one among which is the LSU activator. LSU stands for Louisiana State University activator, and this activator has been modified from that university. So there can be an option question called as an LSU and abbreviated. LSU stands for Louisiana State University activator. And twin block has not been answered. That's the right thing. What is CVMI stage 3 called as? Many have answered transition, which is a right thing, and all the options are in the right order. I at DMC. So stage 3 transition forms the right answer. Moving to the next question. Which stage is best for maxillary orthopedic appliances? CVMI stage 2 and 3. Many have answered this question right. Almost it shows 100%. It's a good thing. So CVMI stage 2 and 3 shows maxillary correction by applying headgears. It's good. And which stage is best for mandibular functional appliances? People have answered CVMI stage 4 and 5. There can be a collision between CVMI stage 4 in both the options, but CVMI stage 3 and 4 stays the best options in all the 4 options. I think so many have answered quite impressively good. Thank you. So can I have any other doubts regarding today's session? If at all you have gathered some questions, you can project in the group chat here.
That was a very wonderful session, Doc. This is Lakshmi here.
Thank you, Lakshmi. Thank you.
Session, and we really got an ocean of information. So I think it'll take some time for the students to go into it, repeatedly look into it, and make a lot of notes, because a lot of points were there. It was very uniform, continuous, and the flow was amazing. So thank you so much for giving us a very amazing lecture on one of the most difficult subject, according to me, in undergrad is ortho, and it was very beautifully explained, Doc. Thank you so much.
Yeah, I would like to say one thing. See, I'm just sharing my knowledge here. Okay, so whenever you're trying to read something, just try to associate with something, so that you will be able to understand and retain things much better. When you also enjoy learning things, and it will be a demand of a less effort putting to remember certain things. So learn for the sake of knowledge, and do not learn for the sake of marks. Enjoy while learning, and for the sake of learning, do not leave your opportunity to enjoy your life. Of course, this is also an important period of your time to go into an examination, to do the examination best, but at the same time, do not forget to enjoy your life. And NEET or the other competitive exam is not an exam to know how much knowledgeable you are. It is just an exam to show how smart you are. If you are trying to do your smart work, it is a very easy exam to crack. All the best to everyone. Have a safe journey to work. Thank you.
Thank you so much, Doc. I can see that you are the one who practices what you preach, because the passion which you have learned, you've just given it to us. You've shared it with us. Thank you so much. And if there are any not much doubts, we can end this session. Or if you have any doubts, you can put it in the chat box. He'll be there to clarify. If not, also the recording will be present, and any doubts you can put it in the comments, and later he will look at the faculty can look into it and they can clarify your doubts. So if there are, I suppose it was a very clear picture, Doc. So I don't think nobody has any doubts.
Thank you.
So thank you so much for giving us a very wonderful evening. And the series is going to continue tomorrow as well, probably around the same time. We'll be having a discussion on endodontics. So I request everyone to give your support for tomorrow as well. Thank you.
Thank you, Lakshmi. That was a wonderful opportunity. Thank you so much. Thank you.